Miel, could I, and Morris and Joe, did you want to? It's my pleasure to chair the last session today, which is nominally called implementation research, but having been involved in ECA Australia from inception, from trying to get the money in the first place to getting the money and rolling it out, and hearing all the things today, look, the whole project is really, from my perspective, it's all implementation, and it's all a part of a huge implementation research project that's not only delivered incredible projects and increased coverage of hepatitis C testing and care and all of those sort of things, and supported by the great work of Jackie and Josh and Anna in relation to embedding in evaluation systems and getting people excited about data and measuring what they do. We've heard a lot about people pivoting and learning from each other. So, and really that's what implementation research is about, is measuring stuff, seeing how we're going, changing and using and sharing information so we can do the job better. But this sort of bit of implementation research that we're talking about this afternoon is specifically around some projects that have been implemented over the last few years around using hepatitis C notification data systems. So I know we're getting to the end of the day, but and people are tired, but what more exciting topic could we finish the day with than data systems and how we can better use data. So I'm going to just hand over to Miel, who is going to talk about the CHECCS project that EC Australia funded in Victoria. Thanks, Miel. Yep. Or I think down.
Yep. Thank you, Mark. And I wish I could make this a little bit more exciting than data. My name is Miel. I'm a project officer with the WHO Collaborating Centre for Viral Hepatitis. My background is nursing. So on behalf of the CHECCS research team, including Jen over there, who's there for all of my data questions, and the Victorian Department of Health. So we worked as a collaboration with the Victorian Department of Health, established a pilot surveillance system-based approach to support the management of chronic viral hepatitis in Victoria. Some of our aims were to identify people who have been diagnosed with hepatitis C, but who had no evidence of follow-up testing or treatment, to enhance access to care and to improve outcomes for Victorians living with viral hepatitis. We also aimed to improve the analysis environment for notifications, monitoring and treatment. I'll mention this as a very brief overview. So there are some slides at the end if anyone wants any further information. But essentially, what did we do? We looked at notifications of unspecified hepatitis C notified to the Department of Health in Victoria from September last year till March this year. We made an initial phone call to the diagnosing clinician 4 weeks from the notification date, collected some demographics and indicators of cascade of care information, and had a discussion with that doctor regarding resources and or referral options for that clinician. For example, links to integrated hepatitis C nurses in Victoria. If the case was considered high risk of loss to care or loss to follow-up, we arranged a second call 8 weeks later. So some of the challenges we encountered, one of them was probably a key difference was access to lab data. So we worked within the first notification database at the Department of Health, and they were in the middle of sort of onboarding an electronic lab reporting system. That was sort of about 3 of the major labs have been onboarded so far, but it was lacking in terms of lab data. So I think in terms of differences in states, there's a lot of different pathology databases in Victoria, and I was only able to access them via phone. So that was a lot of call time. COVID-19, as everybody has already discussed, in Victoria, it created increased pressure on the healthcare system statewide, increasing in workforce shortages, increased call times and difficulty with contacting diagnosing clinicians. They were pretty busy, especially in hospitals and GPs with the vaccination rollout. We were unable to follow up all cases that we wanted to due to workload. It was just me making the phone calls, and there were a lot of calls to make. So we had a bit of difficulty there. and some data completeness challenges. So in 9% of eligible cases, we had insufficient doctor details to allow us to identify that diagnosing doctor. Sorry, I'm talking a lot, so I apologise. Some of our findings, very brief. We had 539 eligible for direct contact with the clinician. Of those contacted, 82% required at least 2 calls to reach that doctor, and direct contact was made with 41.3% of cases of the diagnosing clinician. 35% of GPs requested additional resources, which was really great, and I found that GPs were really receptive to having a conversation about linkage to care. We had follow-up care. We found that follow-up care was less common for those diagnosed in hospital settings compared to correctional facilities or primary care. But overall, 92.7% of doctors contacted had provided or intended to provide care after diagnosis. Of those that were considered potentially high risk of loss to follow-up, we had 28 diagnosing clinicians report that the CHECCS follow-up led to an engagement or a re-engagement of a person diagnosed with hepatitis C. So that was really fabulous feedback to hear from those clinicians. And sometimes it was that person had been recalled a number of times and they weren't being recalled anymore. So that sort of phone call from myself and a discussion prompted a second conversation or a third or a fourth, and actually brought that person back in for either treatment or referral on. Outcomes. So one of the big outcomes of this project that was unexpected and amazingly timely was that we were able to integrate into best practice linkage to care into Victoria's local public health units. It just happened to be at the same time as the project was rolling out. We did get some approval from ECA Australia to actually pivot what we were doing and reallocate our resources. So instead of getting 12 months worth of data of phone calls, we were able to utilize my resources and my project manager, Nicole, to actually support the Department of Health to do some training sessions and provide updated assistance with protocol updates and notification forms, so that now local public health units in Victoria are actively following up notifications of hepatitis B and C, which is incredible. And I believe a long time coming. Diagnosis in hospital was identified as a key area of focus for improving follow-up care, and we established strong links for diagnosing clinicians with Victoria's integrated hepatitis C nurses. And we've made some recommendations. Our final report is coming out very soon, within the next week. The main ones are to continue enhanced surveillance improvement to data. So accessing those lab results, having the ELR completed, and having access and provision of results for RNA results, both positive and negative, would improve efficiency. If I had the results with me, I would have reduced my workload by 50%. So I only was basically contacting every antibody result that I had, unless I had a negative PCR result, which was unlikely. So I know that legislation is coming through, and hopefully by perhaps next year, we might have access to some negative testing data that will make this a bit more efficient. Prioritise cascade of care follow-up for people diagnosed in primary care and hospital settings, and expand cascade of care follow-up to hepatitis B, notifications from the Department of Immigration, and potentially individual level and/or including retrospective follow-up, and optimise the use of integrated hepatitis C nurses to ensure maximum linkage to care. In summary, I guess it's important to recognise that diagnosing clinicians in Victoria overall are doing a wonderful job. And as demonstrated throughout today, there are so many different approaches that are all necessary, and a combined effort to achieve our targets of elimination. And a quote from an integrated hepatitis C nurse, because I've been doing a fair bit of work with them this year. We need to work collaboratively to get the best outcomes for patients. And sometimes the simplicity of having a phone contact to the right person can streamline care for people who don't always fit into mainstream care models. So thank you. And I wanted to thank Department of Health colleagues. They've had an interesting couple of years, as have we all. There's been a lot of changes happening, and we've received a lot of in-kind support from them and from our governance group and the Doherty team. So thank you again, and to Justice Health and Notifying Doctors and Victorian Integrated Hepatitis C nurses. Thank you so much. I probably went over. I could just keep going.
Did I order one? I'm going to say one question from
I'm just going to.
Amanda.
Yep. Mm. Yep. Yes, I think, I mean, off the top of my head, from the clinicians that I spoke to in ED, yeah, there was generally no PCRs that were taken in emergency. Some of the patients that were sort of treated on a ward, even then, sometimes because it wasn't the primary reason that they were in hospital for it, they might have had an RNA taken, but even that wasn't followed up. Some hospitals have individual sort of responses. So some of the integrated nurses that are based at a hospital setting are actually trying to access that data from the lab so that they can individually follow up those cases, but it is really tricky. So if we had a streamlined sort of approach, but I agree, it's often the antibodies taken in ED and then it's a discharge summary to the GP, which doesn't often reach to the GP if they have a GP. So if we did it differently in hindsight, we probably would have perhaps deprioritized as subset of perhaps high caseload GPs and not followed up them, but followed up a section that were referred to a liver clinic, because we don't actually know whether they attended or not. We have no oversight over the 50 or so that were referred. So that would have been something we would have done differently. Thanks.
Should we hold over question maybe for drinks? That's a really good question, Amanda, and it's almost like the reverse. You know, we've pushed all this treatment out into the community, but there's still, you know, a whole lot of points of contacts, you know, in hospital. Next speaker is Maurice Carpenter. I'm going to talk about the work that's been done in Queensland with the NOx surveillance system there. Oh, and sorry, and Linda Felder. Sorry, Linda.
You're not reinstating the timekeeper just before the two of us speak, are you?
Oh my God, overkill.
I got double bubble now. Okay. All right. So first of all, as well, to point out that this part of the team for this was Robert Kemp from Queensland Health, who's sitting over there, and Stephen Lambert as well. So we looked at the notifications data in Queensland with the aim of maximizing treatment uptake in eligible individuals. So specifically what we did was we looked for people who had been notified with a positive hepatitis C test result for the first time in Queensland. So they'd never been seen on the notifiable condition system before. That's NOx, so I'll refer to it as NOx for the rest of the presentation. So those were mainly hepatitis antibody positives. A couple of RNA positives were starting to come through from point of care testing machines and stuff. But some previous research sort of from New South Wales, I think, suggested that people who have an RNA positive test generally get through to treatment. So we focused on that antibody positive test and then looked for an RNA test. And if people hadn't had the follow-up RNA test, what we did then was we contacted the testing clinician rather than the patient to ask about following up with further RNA testing and, if necessary, treatment. We also excluded prison system notifications from this research project as well. So that involved us searching the pathology labs after an antibody positive test for either an RNA positive or an RNA negative, because the RNA negatives aren't sent to the notifying to NOx. And we also randomized those follow-up phone calls to telephone and email. I'm going to go through the numbers really, really quickly because of the sort of time that we've got against us. So in the 6 months of the project that we did, there were exactly 1,162 new notifications. So that's people notified for the first time in Queensland as Hep C positive. Those split just about 1/3 in the prisons, 2/3 in community. And then when we looked at those community cases, some were RNA positive, some already had an RNA negative. Those that required a clinician follow-up were 244. That's 32% of that community total. What was surprising to us out of those notifications that required follow-up was the sources when we looked at it. So you can see there 59% are from general practitioners, but 20% from hospitals and 14% from emergency departments. So nearly 35% of first-time Hep C diagnoses in Queensland are coming out of the hospital system. And that's something that we weren't expecting to see. We then went on with those 244 to actually follow up with the diagnosing clinicians. About 50%, 55% of those ended up being lost to follow-up. Basically, they didn't return to collect their results from whoever had initiated that Hep C test. So that's clearly still a big part of the problem in terms of getting people through that care cascade. 62 or 25% were eligible for further testing or for further treatment. That's 62 people who the testing clinicians were able to follow up with, were able to contact. And from those 62, 26 ended up getting into treatment. So that's what the kind of numbers look like. Some of the challenges that we faced, well, it was, you know, this started at the beginning of the COVID-19 situation, pandemic. Although I've got to say, was it Winston Churchill who said, never let a good crisis go to waste? The beginning of a global pandemic isn't the worst time to ring up GP clinics and hospitals and say, I'm calling from Queensland's notifiable condition system. I'd like to speak to Dr. So-and-so about one of their patients. I was put through pretty quickly to most GPs. Doctors on hospital rounds were paged to come to the telephone. All right. So if you're getting some mileage out of it, you know, get what you can out of it. Data management and sensitive tasks. So it just, I mean, I complained about the workload in the last project. It sounds like I just whinge about the amount of work I've got to do, but every week, because communicable diseases branch were taken up with all the COVID testing that was going on, I ended up having to do all of the testing through the pathology labs. 3 of the labs in Queensland we have online access to. The others, it's still a matter of picking up the phone and talking to people and asking them to manually search. Now, if we didn't have an RNA test that week, you know, we'd have to go through the same list the following week to try and find people. The point is that it's not about workload. This is 2022. There must be a more efficient way of finding RNA negative tests, and by picking up the phone and asking not, you know, labs to search through them, or through searching through screens manually online. In terms of the findings, well, we did end up with sort of increased knowledge and understanding about the NOC system in Queensland. I think Robert would say that, you know, there's a better understanding now within Queensland Health and Communicable Diseases branch about where these notifications are coming from and the kind of resources and effort that's required if we're going to start following those up. Undoubtedly, following those notifications up can lead to increased testing and treatment, and it did. And I think a really important finding is this high proportion of hospital-based notifications. When we did the evaluation interviews, a lot of that was coming from incidental testing that was taking place in hospitals, in EDs, oncology, you know, people getting screened before cancer treatments and things like that. But those first-time notifications weren't getting followed up. So some of the clinicians did say to us that if they knew that these test results, these HCV test results were diagnosing people for the first time, that would kind of increase the pressure on them. They'd be more likely to follow up with the testing. How we achieve that with the way the testing system's currently set up, I don't know. And then hospitals and EDs need to develop really better processes for following those notifications through to, you know, people's GPs, or to find somebody who is better able in the community to manage that hepatitis C case and get somebody tested and get them through to treatment. A lot of the successful cases that came out of the hospitals and the EDs, I felt that I was just providing the link between the hospital doctors and people's, you know, community care in terms of getting that stuff followed up and tested. With that, I will hand over to Linda, who will bring this up to date with the other stuff that we're doing in this stuff.
Yes, so this year we decided to do a pilot on looking at historic notifications. So what Morris was doing was notifications as they were coming in, and we initially hoped that Morris could do both because he's a Superman, but he's not quite such a Superman. So working again very much with Queensland Health, and Robert Kemp did quite a bit of this work, as did public health trainee at UQ, Mecula Fernando. So what they did was look over a 4-week period in June, notifications from 4 time periods, 2018, 2013, 2008 and 2003, who hadn't been in prison, and the screen for whether or not they had died. Initially, Mecula searched all the pathology databases again to see if there had been any subsequent testing. So she was particularly looking for whether or not they'd had a negative PCR test, and that could have happened at any time after that initial notification, but also to get more recent contact information. Then Robert, if they couldn't get contact information from that, then Robert looked through the public health viewer, public hospital viewer, to see whether or not there was any other data available. They initially followed up with the clinicians if there was clinician available, and if not, directly via registered post or text message to the clients themselves. So as you can see from the data, and it was what you might expect, there was rather dwindling, depending on how far back you go, yield in terms of being able to find contact details. Also that if the further back they were, the less likely we were able to find that they'd had a negative RNA test at some point. So that both, as you can see, are totally either through clinician or through text messages reduced over that time period. Robert and Mecula then tried to get further information, but that became a case of diminishing returns. So we've closed off the project. We've got very little data on what happened to those patients, but we do know that it may be worthwhile following up more recent notifications, but probably not the really ones way back. But the other thing that Robert mentioned was that COVID was also a bit of a blessing here, because all that COVID testing meant that we had a lot more contact details for people than we otherwise might have had. Thanks.
No time for questions. Was that what the stop was? Okay. Questions for drinks and over drinks, and couple of overlapping themes there, the hospitals and just the importance of negative RNA reporting. Overwhelmingly the notifications are based on antibody results. Would save an enormous amount of time if we had that negative RNA data. Next, I'm going to hand to Joe Doyle, who's going to talk about some work that we did in Tasmania. Thanks, Joe.
Thanks, Mark. Good afternoon, everyone. Second last talk for the day, I think, aren't I, Mark? You get to finish, so you can sleep in a second after I talk. I'm just going to start echoing the acknowledgement of the traditional custodians of the lands in which we're meeting, and also acknowledge the work I'm presenting here is a collaboration with Burnett people, including Mark and Margaret and Elisa and Jackie, and our colleagues in Tasmania, Louise Owens in the room, and her colleagues at Tas Health, including Kate Turner, Faye Johnson, Mark Feach, and your nurses, Rachel, Karen, and I hope I didn't, and I want to particularly single out Tafi, Murakudif Tafi, who is over in New Guinea at the moment. Marakatira, that's right. And Tafi couldn't come down from New Guinea to talk today. So what did we do in Tassie? We thought that echoing these other ideas about notifications in a single jurisdiction where there is great data capture and a smaller geographic area than the rest of Australia, could we actually look at every sequential prospective notification and link those people actively into care to try and increase care and treatment? So that's really what this project, the Connect study, is all about. And I think the background's pretty familiar. We need to try and work out ways of enhancing treatment uptake. We know that linkage to care is one of the big barriers. And this led to this aim and hypothesis that we thought that having a public health nurse or a specialist engaged nurse in the health department where the notifications are coming in, if they made contact with the prescribing doctor, the doctor who's ordered the test, and just remind them that the test has come, offer maybe extra support if that doctor didn't know what they needed to do to start someone on treatment, and even offer the opportunity of talking to their client, their patient, if they wanted to. That might be a way of improving the cascade of care. The comparison in Tasmania, like in a lot of jurisdictions, is that a letter goes out saying this new notification's arrived with some information. So that has been, I think, become the standard in most jurisdictions more recently. So what we propose to do is over a year, 2020, great year. This was proposed in end of 2018, 2019, but it started just before COVID hit and continued through 2020. We were looking at prospective notifications. It involved a telephone call from the nurse from the health department with or without the escalation to patient contact. And the primary outcomes that we were looking for is what proportion of people got started on treatment within 3 months of that first notification. So this is a pretty short time, but when we look back what was happening in Tassie, and I suspect this is similar to other states, it was only about 8% of people starting treatment within that time. And it might have even been not that much more over an entire year. So we thought, we'll come back to this, but we thought there was a low, across the whole country, relatively low base. We were proposing we could improve this by about 25%. So on that basis, we'd powered this study, and it was randomized 1-to-1, so that one person, one notification, would get the letter, one notification, would get the phone call, but it was random, of course. There were other outcomes we wanted to look at. What about completing RNA testing? Because this is mostly antibody. What about completing all the blood workup? And we also thought, what if we looked a bit longer than 3 months if we had that data? So I'll come back to those secondary outcomes too. Importantly, the GP was the person randomized. It wasn't about patients. It wasn't about written consent. What happened was that notifications came in as normal. And when we made contact with the doctor, either to get the outcome at the 3 months or to offer the intervention, we asked the doctor whether they would verbally consent to be part of it. That was the way the ethics was designed. And so the doctor was the person randomized. If they got a second if they made a second notification over that year, they stayed in the same arm because we couldn't switch them from, intervention to not. They'd sort of already, we hypothesized, had been trained having had the first time. I'll come back to that too, because that's probably something to talk about. So we needed 85 GPs in each arm, which was roughly 9 months of notification data in Tassie based on history. I've touched on the outcomes already. So I'll just make a comment about the intervention. It's hard to design this intervention. You can call it enhanced follow-up from a public health nurse, but of course, sometimes you just call and the GP doesn't need any help at all. And that's what we sort of level zero. We tried to record how much effort was put in. So that was like no extra support really. The doctor was aware of the test. They knew the result was positive already. They didn't need any help. There was a little bit of extra support where some general information about hepatitis C was given. Then some more moderate support where some diagnostic advice was saying you now need to do an RNA. The RNA tells you whether you need to offer treatment. And then there was an extra support, again, the more individualized support, because these nurses were trained on how to offer Hep C care advice. And finally, there was this model, this offer of giving support direct to the patient. And then that was rarely taken up, as it turned out, because GPs generally said, no, got it under control. So that was what tended to happen. Now, this is just I'll drill down to some detail in a moment. But I'll just point out that there were, in this year, 372 notifications. We were only looking at primary care for the trial. So you can see there's 150 is that cursor showing up? It's not showing up. Yeah, so there's 151 who get excluded because they're from hospitals or correctional services or coming from specialists primarily. And sometimes it's also, they were just, so we ended up enrolling 171 GPs and randomizing them, about 85 and 86 in each arm. I'll switch to the next slide, which drills down to the results really. So there's 111 versus 115 individual cases. So that means that there were some GPs who made more than one notification, about 25 or so in each arm. Here's the final headline result. In the treatment intervention, the nurse intervention, 41% of people got started on Hep C treatment within 3 months. And I think that's a really amazing result. But look what happened in the control arm, 33% of people also got started on treatment. So This is the glass half full, glass half empty. I think it's a really fantastic result and good news story that we can actually have a huge treatment uptake in a short period of time, especially when we look back at data over years saying that we would never have done that in the past. But there's no significant difference, and we can't use this trial to conclude that this intervention will improve treatment uptake. There was a difference in one of the key secondary outcomes. We could see that we got nearly 9 out of 10 people to have an RNA test in the intervention, but it wasn't bad. It was 3/4 of people getting an RNA in the standard of care anyway, when that letter arrived and the GPs knew what was happening. The positivity rate wasn't very different. Just to point that out, it's about 1 in 3 people were positive. That probably reflects that a lot of these notifications were in people, remember it's antibody, they'd already been treated, they'd already been diagnosed before, and that's standard in health at the department level. There's a lot of repeat notifications and a lot of work goes into deduplicating. And also the pre-treatment workup had been done in 2/3 of people in both arms as well. So we didn't have any impact there. This shows this graphically. So the notifications, intervention left and right, you can see that we could get more testing. The positivity rate was similar. The pre-treatment workup was similar, but the initiation was that 41% versus 33%. So what can we say about this? Firstly, there haven't been any prospective randomized trials like this, not in Australia and not overseas, because it is actually hard to randomize this sort of thing. But we thought it was important because if this worked, it would be really instrumental in pushing health departments to say you need to fund people to do this. We do it for COVID, don't we? We do it for TB, lots of other things like that. So I think we can show that there's an improvement in getting RNA testing and there's a trend toward better engagement and care. But importantly, we couldn't prove treatment uptake increased. But I think this is where we have to reflect what the lessons might be. Whilst there's no apparent difference, we certainly saw a much higher than expected treatment uptake in our control arm. So I have to say well done to Tassie GPs, because that's reflecting, I guess, the education, the penetration over the year before, when actually EC and Tassie were doing other things to educate GPs. Maybe we did, you, Louise, and your team did a fantastic job and got that to a level where we weren't going to see that jump that we might have expected. It's also important to think that there could easily be dilutions, because GPs, and what we mean by that is that you're seeing not as much difference because Jackie wants to say something in the back. Possibly because this GP got another notification, they already knew it was going to happen. So it's possible that that means it looks like there's less difference. And potentially we also assess things a bit earlier at 3 months, but where we could look a bit longer, it didn't seem to make a difference. So I'd say the main lesson, this could still be very useful in an environment where there's not much treatment uptake. And this would be a short-term, potentially a short-term solution to try and improve both completion of diagnosis and maybe have a better impact on treatment uptake. Thanks, Jackie, and everyone else.
Two other take-home lessons is that a nurse can lead a clinician to water, but they can't make them drink. And that it doesn't matter if you have the most whiz-bang statistician doing the power calculations, as in Tim Spellman, when you make up the input data and the data's not right, it's, you get an underpowered study. Oh, we've got 2 questions. Jackie's been saying, are we all right to cut into? Back there. Joe, we've got some questions.
So my comment would maybe be that the GPs that are testing are already sort of on board and they're fairly competent at managing it and signing people up, whereas the people who aren't testing might benefit from your intervention, but you just didn't pick them up because they're not identifying people in their practice.
Yeah, that's a really important other alternative. I mean, it wasn't reflected in the data a year or 2 before though. So there had been that change as well in testing practice and education and I guess treatment experience of GPs.
Joe, I know I tried to get you to cut this data every possible way, just so that people know to see whether I could find something that I could work out. It just, have we, just suddenly think of it, if we look back at Tassie for the 3 years beforehand with access data or any other data, what was GP uptake? Like, did we really So your
we-
thing that this might have been not in a greenfield site, I think is something we need to reflect on, because otherwise it looks like we may not have had impact. Have we got a background thing? I've forgotten. You probably told me when I asked you about 12,000 questions about this one day, but what was our background 3 years before we went to Tassie the first time to do the work with Louise and crew and the education back then?
I can tell you 12 months, not 3 years, and it was 8% of people
That's what I
who had
thought.
been notified to the health department. Sorry, the notification numbers were the same as what we had. Let me make them clear because they're not linked. And secondly, treatment uptake had been 8% in Tassie.
Yes.
So the trouble is, because as everyone, a lot of people in the room would know, you can't link treatment notifications, disease notifications to treatment very easily. So you can assume that they go together, but to the comment about, there's going to be a lot of treatment uptake, which is happening not in someone who's just diagnosed, and the people who are being diagnosed are certainly people who might be just about to start on treatment. So it certainly can work in both directions.
Jason, I'll be
8%
having a
was the
chat.
number. We could try again. Certainly in the Hep C world, it wouldn't be without precedent for someone to do a trial and have one arm and compare it historically to what used to happen. Because does anyone remember when the DAs arrived? That's exactly what they said. They said, 90% cure compared with the past. They never had the control arm. So if you looked for 3 years at 8% uptake and we got to 41%, it's a win, but it's not randomized.
I'm not sure if I missed it, but was every GP invited to be part of the study, even those who weren't part of the intervention? Did
So
they all agree to it?
So it was sequential. So what happened was the notification arrived, and then within the health department, they either just did the normal process of sending a letter out, or randomly that notification was assigned to have the phone call, and they would phone the GP and ask whether the GP wanted to receive that phone call. I didn't show you the slide. 10 out of 120 declined to participate, but equally in the control arm, when they called them to see what had happened to their patient, about 10 out of 120 said, I don't want to give you that data. So the lack of participation was less than 10% in both arms.
Thank you.
Oh, goodness.
I'm enjoying the
me.
microphone, Jackie.
I know. You're really winning this one, Joe.
This is probably for everyone who's done the notification follow-ups, but were there differences across, I guess, the number of notifications per GP? So high caseload versus low caseload, and were there differences there?
We tried that one too. Didn't have a difference. We couldn't censor the more treatment experienced higher notifiers out and see whether the first notification had an impact, because makes a lot of sense, doesn't it? If you hadn't notified many people in the past few years, you might have been more likely. But remember, the numbers are pretty small for that. That might actually be important, but when you're dealing with only 85 GPs in each arm and then you start to cut them out, it doesn't work. Elisa's now told me to stop, so I'm really stopping now.
I thought, Elisa, you were putting your hand up for a question, no? Was that just to stop it? Yeah, and most importantly, that's mine. So. I'm going to talk about the future of what we're going to do in this space. And I've nominally called, you can get off if you want. Nominally called Connect 2. The Tassie study was called Connect, and I'm going to call it Connect 2 until Margaret, who's great at naming studies, tells me it's rubbish and she wants something else. But I'm calling it Connect 2 for now. It's an NHMRC partnership grant that we were successful in getting last year, second time round. And I'll just go through a little bit of an overview of where this is at. I would like to pay my respects to the traditional owners of the land that we meet today, and pay my respects to their elders past, present and emerging. Just a little bit, my God, that is small, isn't it, that everyone's been talking about. So I'm going to turn around. The background is, look, we've done extraordinarily well in the DAA era, treating 90,000, 100,000 people. But we know that treatment numbers are declining, and we know that testing rates are insufficient to drive us towards elimination, or, we're right on the edge of dipping below the line. We can't do more of the same. We wrote this paper last year that was sort of based on a diffusion of innovation theory, where we can't just rely on persuasion through social systems to just get people in to treatment, just try and convince them, we actually have to adapt and make structural changes to what we're doing to allow it to make it easier for people at risk of hepatitis C to get tested and treated. And a lot of the work that we've been talking about today is exactly those systems changes, the involvement of peers, outreach, nurses, and getting into environments that we haven't traditionally been. We can't just say we've built it with DAAs and people are just going to come, because that's not going to work anymore, particularly later on in the as we approach elimination. So the overall aim really here is to look at the opportunities held in this notifications data to guide pathways into care and treatment and cure. It's really important now, but I'm going to argue that it's even going to be more important as we approach the final phases of elimination, because as our anybody remember this? I love the last episode of The Bachelor. What are you looking at, Jackie? The final phases of elimination. There's only 2 left, Jackie. Jesus. Yeah. Anyway, Margaret, I'll educate you in popular culture later. Sorry. As we approach the final phase of elimination, the case numbers are going to get smaller and smaller, and it's going to be, like finding a needle in a haystack. We're going to have to do a lot of testing to find cases. So utilising health systems and health systems data, I think, is going to become more important as we, are approaching 2030, and hopefully we're approaching, that threshold of elimination. So really, the aims of Connect2 are to identify and address regulatory and operational barriers across the country, every jurisdiction in Australia and health departments, to identify models that are acceptable to follow up people, acceptable to community, to government, and to clinical practice as well, to use that information to implement and evaluate systems in each state, and to undertake epidemic and cost effectiveness modelling of some of this work to identify the most effective and most cost-effective ways to drive us towards achieving elimination. We will orientate this work to jurisdictional priorities and structures, the balance between prospective and retrospective, thinking about the technical and workforce capacity in states, centralised and decentralised public health units that we have around the country, and how different systems might work for different places. Building on the work that's already been done that we've heard today, but also the work that's happened in South Australia and in Western Australia and in New South Wales in the local public health unit in southeastern Sydney. And importantly, to create a platform where we can share learnings across jurisdictions, and we can learn from the practices of each other. Nothing better than a framework, right, Margaret? Margaret loves frameworks. So in any NHMRC grant, particularly partnership one, you've got to have a framework. So really phase 1 is about creating that enabling environment. We particularly want to work with governments and local public health units, but also Solicitor General's offices, the lawyers, to understand the regulatory and legislative barriers to sharing data. There's a lot of confusion out there about what we can and what we can't do with data from a privacy and a public health legislation perspective, and create that enabling environment also with thinking about community attitudes, particularly people with a history of injecting drug use, and what's acceptable to community in relation to making direct contact with patients, direct contact with their new clinicians, who may not know they've even got hepatitis C. Those types of things, and also with care providers, what's an enabling environment that we can create there to make this acceptable to clinicians who are diagnosing people or providing care to people that they may not know are hepatitis C positive. The phase 2 is really that implement and evaluate, as I said in the previous slides. And then to look at that analysis, the phase 3 is that modelling, and research translation is to understand of all the things that we're doing around the country, which ones are the most effective, which ones are the most cost effective, and maybe that might vary according to different environments, the geography of the state and the clustering of where notifications are coming from. That's the outrageously ambitious timeline that you always put to the NH and MRC and go, yeah, we can get this done, not a problem at all. And I'd just like to thank the usual suspects on the left-hand side, but all the partners that came on board for this partnership grant. These things are the worst types of grants to write. And I'd really like to thank all of the state and territory health departments, the local area health services down the bottom, and the community organisations at the top for all signing on to this project and supporting it over the next few years. Thank you very much.